You are listening to Hit Play, Not Pause, a feisty menopause podcast for active, performance-minded women. I am your host, Celine Yeager. Each week, I bring you advice from athletes, scientists, researchers, and other experts to help you feel and perform your best, no matter what your hormones are doing. This show is a production of Live Feisty Media. Hello, strong, feisty women. I hope you all are well. All right, so I'm trying something a little new here for the new year, and I'm going to be doing some regular episodes looking at research with our resident reproductive endocrinologist and multi-time guest, Dr. Carla DiGirolamo. Since menopause has really taken off in the public consciousness, there's just a lot more information out there, and there's a lot of research and research reviews that are coming out on a regular basis on the care of perimenopausal and menopausal women. So I thought it would be informative and honestly kind of fun to have Carla come in on a regular basis to break down key studies as they come out, which is exactly what we'll be doing this week as we kick it off. For those who are new here, a little introduction to Carla. She is an MD, PhD, double board certified reproductive endocrinologist and obstetrician gynecologist, specializing in infertility and menopausal medicine. She is also a CrossFit Level 1 trainer, a certified nutrition coach, a member of CrossFit Health. She is a MedFit care provider, and she also has her own Substack, Athletic Aging, where she provides weekly workouts and medical updates. And if that's not enough, she's an endocrine consultant for Wild Health. Most recently, she has launched her own private practice now, and she is available for consultations at drcarlad.com. I will put that in the show notes. You can check it out. She is helping women on all spectrums from puberty to menopause optimize their performance, and it's very exciting. I'm very excited for her. Okay, so on a high level, just because we get into the study a lot, I don't need to go into it too much in this intro. High level, we looked at a study that was published last month in Menopause, which the aim of the study title was the range and variation in serum estradiol concentration in perimenopausal and postmenopausal women treated with transdermal estradiol in a real-world setting, a cross-sectional study. So very simply, the aim of this study was to explore the range and variation in serum estradiol concentration, those blood levels, and to estimate the prevalence of quote-unquote poor absorption, women using licensed doses and getting subtherapeutic levels, quote unquote subtherapeutic, in perimenopausal and postmenopausal women. And I really wanted to dig into this because there was a couple of things that I wanted to explore more. The first one was what hormone testing itself tells you and what it doesn't. And importantly, we really dig into this notion of therapeutic levels of estrogen, which in this study have been pulled from pretty old studies that are more than 20 or 40 years old at this point, and dig in a bit on like why working off levels can be problematic. So there's a lot to chew on in this one. And I know that many people out there, many of you do like to know your levels. And I think it's just worthwhile digging in on why the menopause societies don't recommend aiming for any specific therapeutic levels and what these levels can and maybe can't tell us. As always, science is ever evolving, so we'll just continue to keep an eye on all of this as thinking evolves over time. Okay, before we get into it, once again, I want to take a moment and invite you to join us for an incredible, drop-dead, gorgeous gravel cycling week in Girona, Spain at the end of April. It is literally one of the best places on earth to ride, which is why all the pros train there. I have heard from a few of you who are a little new to gravel and you're worried it might be too technical. Do not worry about that. The technical difficulty here is one, the lowest level. It is a lot of champagne gravel through beautiful scenery. And it's just a week that we are planning on soaking in the amazing views while also connecting to help each other through whatever challenges we may be facing during this time of life. And I'm really looking forward to it. And it promises to be a transformational week. So I just hope you can join us. I will put a link to that in the show notes. You can check it out there. While you are in those show notes, sign up for my free Feisty 40 Plus newsletter where I share research and news you can use each week. Give us a follow on Instagram and Facebook at Feisty Menopause. And if you like the show, share it with a friend. It helps us to continue grow as we are going into our 5th year. All right. Very quick thanks to MIDI Health for their continued support. I hear from so many women who are loving the ease with which they are getting all the support they need, the therapy they need through MIDI. So thanks so much for your continued support. All right. Enough of me. Let's have a few words about our awesome sponsors and get on with the show. All right, Carla, thank you as always for being here. This is going to be a good and timely discussion, I believe.
Absolutely. And as always, thank you for having me.
So, broadly, what I would like to accomplish in this conversation is I want to cover two areas of great and I believe growing interest. One is just hormone testing broadly. It's something that we had always seen in the functional medicine space, I think, and it is definitely becoming more commonplace outside of that. Now, I see more conventional doctors do it. I see more people talking about it. I see it popping up on Twitter in ways that just make me think this is something we need to keep talking about. And related, I want to talk about that hormone testing being used to aim for certain blood hormone levels when specifically when we're talking estradiol for symptom and health management reasons. So I thought the best way to do it, I had sent you a study that we'll be talking about that was published in the journal Menopause just this month. And it really covers what we're talking about here, hormone testing and therapeutic levels. So let's talk about it. The study was the range and variation in serum estradiol concentration in perimenopausal and postmenopausal women treated with transdermal estradiol in a real world setting, a cross-sectional study. And boy, this study does cover it all. The aim was to explore the range and variation in serum estradiol concentration, and just mostly to estimate the prevalence of quote unquote poor absorption. So women using licensed estradiol doses with sub-therapeutic levels, which we will get into. And the results they found, 1 in 4 women, 24.84%, using the highest licensed dose had quote unquote sub-therapeutic levels, which they define as less than 200 pmol per liter. Did I say that right? I always read this stuff and I don't say it. So is it pmol?
It's picomole.
Picomole. Okay.
Picomole. Yeah, it's the metric system as opposed to nanomole, as
So bad at
opposed
the
to,
metrics.
yeah.
So bad at the metrics.
Yeah.
I'm a US person. We
Yeah.
just don't do it yet. Anyway, so those were the study conclusions, which broadly were saying we should be testing because we don't know if women are absorbing and we do not know if they have therapeutic levels. So there is a lot to unpack, and let's start unpacking it. Let's first talk about this measuring hormone levels idea. How should we think about it? I thought the study was illuminating insofar as the women do appear to have very different levels of absorption rates and levels when you're talking about this transdermal application. And that does seem important.
It, it is important. I think what's very important whenever you run a test, whenever you order a test on a patient, you first want to define what do you want to learn from this test? What's your question? What
Yep.
question are you trying to answer by doing this test? The second thing is you need to know what that test is going to tell you and what that test is not going to tell you. And so you obviously apply that to the question that you're trying to answer. So now I've been a reproductive endocrinologist for 18 years, and I order more hormone levels than anybody on the planet. But again, the key is knowing why you're ordering them and what they tell you and what they don't tell you. So when a client comes to me with menopausal symptoms, hot flashes, or whatever, the first thing I want to know, and this is why I have an hour-long visit with all of my new patients, is I want to know what the experience is. And so when she's giving me her symptoms, I make a list in my mind. It's called the differential diagnosis. And, could these symptoms be caused by thyroid disorder? Could these symptoms be caused by, by anything really? Androgen excess? Does she have polycystic ovarian syndrome? What are her symptoms? And then I outline a number of tests that I want to do to identify the reason for the symptoms she is having. So my why is, why am I doing the test? Because I want to figure out the cause of the symptoms and the experience that she's having. So I'll order a bunch of tests to help me answer that question. Now, the other reason why many will order tests is in a lot of the direct-to-consumer marketing of like Inside Tracker and the Dutch test. And these are great companies that do a great job with their tests. Don't get me wrong. They do a really good job. But again, why are you doing them? You know, what is the question you're trying to answer? Okay, I just want to see where I'm at. Okay, well, if you do a Dutch test, that's going to tell you what your steroid hormone pathways are doing in an instant of time that you did the test. That's what it's going to tell you. And what it's not going to tell you is a lot about other non-steroidal hormonal pathways, like the insulin pathway, your reproductive axis, your FSH, LH. And even though you're checking estradiol and progesterone, there are a million different combinations of FSH and LH that'll get you to those endpoints of those steroid hormones. So the thyroid hormone system is also not a steroid hormone system. You're going to miss some of that in the traditional Dutch test. So you have to, it's really important to know what these tests are going to tell you and if they're going to actually answer your question.
So are you, when you were talking about your hypothetical woman who comes into you with certain symptomology that's pointing towards perimenopause generally, are you including any or sex hormone, ovarian hormones in that test when you look at her?
It depends on her age. If she is under the age of 45, I will check an FSH because people shouldn't necessarily be overtly menopausal at under 45. You're usually starting to see some variations in those labs in the early 40s. But you don't usually see dramatic changes. Like I wouldn't expect in a 42-year-old woman to see an FSH of 100.
Right.
I wouldn't expect that. And if I saw that, it would tell me something very important. It would tell me that, okay, she's probably in early menopause. Or going down that road or in early perimenopause. She's going
And
through
just
this
and
earlier than
just
she should be.
yeah, and just for people who may not know, super brief explanation of why that would be a flag for you, that what FSH is telling you.
So, follicle stimulating hormone is a hormone that we produce from our pituitary gland that basically drives the menstrual cycle. It tells the ovary it's time to make an egg. And FSH is cyclically produced every single month in the same way in people with regular menstrual cycles. And then what happens is in perimenopause, when the cycles are starting to become more irregular, the FSH levels are starting to become more erratic and they are rising. And then by the time someone is menopausal, when their cycles have stopped, that FSH is at a much higher place. It could be 100, 150, whereas the normal range in a reproductive age woman is less than 10. So it's dramatically different when you enter that stage of life. So in women 45 and older, I don't check the FSHs because they're all over the place. It doesn't really tell me anything. Her symptoms are going to tell me if she's perimenopausal or not. But in someone who's younger than that, who I wouldn't necessarily expect to be down the road that quickly, I would check them in her. So there are very specific circumstances when I check certain hormones.
And you would not necessarily check estradiol or progesterone because of the same reason of fluctuation?
Yeah,
Yeah.
absolutely, especially in the younger population. I mean, typically when I do hormone testing in people who are cycling, the ideal time to do it is on day 3 of the menstrual cycle, where the first day is full flow and the third day is, 2 days after that. The levels that I see can be interpreted much more accurately when we do it at that baseline level. When you don't know where in the cycle the person is, you could see those FSH levels, estradiol levels, progesterone levels all over the place. So it's really helpful to know where in the cycle one is when you're getting those lab values specifically.
And what about with a perimenopausal woman who's not having regular cycles?
I would check a thyroid.
Okay.
Someone who's 45 and over, her FSH is going to be all over the place no
Yeah.
matter what. It's just not helpful. What I
Yeah.
want to know is, does she have a thyroid disorder that is undiagnosed? And, what are the other reasons? Does she have PCOS? Because you can have PCOS and be older. Is this hyperandrogenism? And so those are the things I would focus on more in a 45 plus patient. Whereas in the younger group, where I wouldn't expect perimenopause to be happening so soon, I would also include the FSH and the LH.
Excellent. So then let's talk about the use of hormone testing to guide treatment or to quote unquote achieve therapeutic levels. And let's talk about that idea of therapeutic levels. So I guess first, would you, if you had that hypothetical woman and you decide she could benefit from a form of hormone therapy, let's call it the patch because that's very prevalent right now, or a gel. Would you check her levels to make sure she is getting the hormone? Like the absorption seems to be an issue here. So do you go that route to make sure that she's absorbing, or is
Not
there another?
immediately,
Okay.
unless I have reason to.
Okay.
I've treated hundreds of menopausal women, and when I start them on the patch, typically, and if they're achieving symptom relief, then there's no need to check the levels because the
Hmm.
level isn't as important as the symptoms. If the symptoms are, if this woman is feeling much better and her life has changed, I don't really care what her level is,
Yeah.
right? If she's on a normal dose. Testosterone is a completely different animal because you have to make sure people are in a safe range because
Yeah.
in ranges outside of the physiologic range for reproductive age women can have side effects and some permanent, things that we don't want to have. So the exception is testosterone. But for just normal hormone therapy, I do a trial, see if it helps her symptoms. I start at a pretty standard dose usually, and then go from there. If she comes back to me 3 months later and says, well, things are helping a little bit, but I'm still not getting any relief, I might go up to a point, you know, 0.75 patch. And then if she comes back to me and says, I'm still not feeling anything, I might check a level to see if she's absorbing it because she really
Yep.
should be. And the vast, vast, vast majority of women do. And then if I see that the levels are in the ranges that, the paper talks about, if it's in the physiologic range for like a reproductive age woman, I might think, okay, well, she's absorbing this. But what else might I be missing? Maybe this isn't. Maybe these symptoms are not hormone related. Maybe I need to now go back and recheck my list of my differential diagnosis to see, am I missing something? If she's not absorbing it, then I may say, well, let's try a different method of delivery. We're on a 0.075 patch. Your estradiol level is still 10, which is
Hmm.
really super low. I might say, let's try the Divigel because, maybe she's a triathlete and she puts the patch on and she sweats it off. That happens a lot. And the gels can be a little better for athletic women because you just rub them in and you don't have to worry about sweating them off. I believe they're a daily application, so they can be a little more, compliance driven. But instead of just continuing to jack up the levels, I would try a different mode of delivery. There's vaginal ways that we can give
Hmm.
estrogen. There's, estring, not estring. It's I forget the name
The
of the system.
femring is the one that's
Ephemerin, yes,
yeah.
ephemerin.
The estring's
Yeah,
just local. Yeah.
yeah, because, ideally you want to use, and this is supported by 10 years of position statements from the Menopause Society, that you want to use the lowest dose that is effective for treating symptoms. Because as doses increase with estrogen, and I know we'll talk about this later, the side effects and the risks increase as well. So my main focus is a woman's symptoms. I want to hear what she's telling me. I want to hear what her experiences are. And I use levels of hormones as a tool to help me figure out why she's still experiencing symptoms and why she's not getting any relief.
Yeah, and we will come back to that because I very much want to talk about, and we can talk about this a little later after we wrap up the paper, but I am very keen to talk about the idea of shooting for this stable level that is physiological only sometimes in a reproductive woman's life to keep it that way all the time. There's something in that that just strikes me as I think about it that I want to dig further into. Before we get there, let's talk a little bit because before we started recording this and as we were, going back and forth with the study, you had mentioned that there's a difference between how the UK measures it and how the US measures it. So let's establish that before we start talking about what they're talking about as therapeutic levels, especially for bone health, which we'll get into in a minute.
Yes, and this actually almost tripped me up. And I'm someone, like I said, that I read these hormone labs all the time. I order labs, and I stare at this all the time. And this almost tripped me up. The UK uses a different um, unit of measurement than the United States does. So in the UK, they measure estrogen in picomoles per liter. Okay. In the United States, we measure estradiol levels in the blood in picograms per milliliter. Two apples and oranges, different sets of units. And so in the picomole per liter in the UK system, those numbers are a little bit higher. So when we were reviewing this article offline, I'm looking at these levels saying, oh my God, these are high levels. These are like levels that a reproductive age woman only achieves during like 2 days of the month during ovulation. But then when I dug deep into the paper, I said, wait a minute, I got to do the conversion. So then, of course, I go online, I got to figure out what the conversion is, and then realize that in a US system, it's a little bit lower. Not
Yeah.
by a lot, but it is lower, and it is in a more reasonable range where a woman spends a little bit more of her time. So, if that's going to trip me up, a general OBGYN reading this paper or a family practice doctor reading this paper, they
Yeah.
might say, oh, we got to shoot for 200 to 300. She's in the United States, and now she is ordering way too much estrogen for this woman simply because it's a different unit of measurement. So if it's tripping me up, I'm sure it's going to trip up somebody else. So that is important for everybody, clinicians and patients who are having these labs done. You want to make sure that they're being interpreted properly and advocate for yourself.
Yeah, 100%. So now that we've established that,
Mhm.
um, let's talk about what the paper had to say about therapeutic levels, because the point was that a quarter were not absorbing enough to achieve at least 200 picomoles per liter or about 60 picograms per milliliter, which is they define as what you need for relief of menopausal symptoms and prevention of bone loss. And that's what made my ears perk up and my eyes perk up and say, I need to send this to Carlo and figure out what we're talking about and where these therapeutic levels are coming from. Because in the study, they pulled two papers that they cite in that area. One is from 1985 and one's from 1996. So there has to be more recent research showing this. What do we know about quote unquote therapeutic levels?
Well, if you look at the Menopause Society position statements on hormone therapy back as far as 2010, and they've done them every couple of years since then, they have held the universal position that laboratory values correlate poorly with symptoms.
Okay.
And I would suspect this is the reason why we don't see much recent literature on it, is because this is pretty well accepted because women's experiences are very, very different. Now, sure, if you have a menopausal woman, her baseline estradiol level in her blood is going to probably be somewhere between 5 and 10, maybe. If she's a heavier woman, it might be a little bit higher because of the estrogen that lives in adipose tissue. But say she's a lean woman, probably between 5 and 10. If I prescribe her a 0.05 estradiol patch, her estrogen levels are going to go up. She may say hit 60, which is fine. That means she's absorbing it. And she may tell me, oh my God, my life has changed. Things feel great. I'm on my way. So I could have another woman, exact same situation. I could put that 0.05 estradiol patch on her, and she may have levels up to 150, and she might tell me that I'm not getting any relief from my hot flashes. So, is there a rough correlation or association with higher serum estradiol levels and lower hot flashes? When you're prescribing this, of course, when the estrogen goes up, the hot flashes are treated. That's the whole reason why we prescribe the medicine. But to have these universal ranges, which are pretty narrow, to say that, okay, we got to shoot for this level to cure your symptoms. Well, why don't we just focus more on the symptoms? And if the symptoms aren't being treated, check a level, see if she's absorbing it, but you have to entertain other reasons for her symptoms. And, this is the thing that bothers me a little bit about this tech era. You know, Doctors these days, these kids today, I'm going to sound like my grandmother. These kids today use all of this technology and they haven't spoken a word to the patient. And how frustrating is it for us as menopausal women to go to our doctor and feel like, okay, I'm ready to jump off the roof. I'm ready to have a mental breakdown because I can't sleep. And your doctor says to you, oh, your levels are all fine. Go home. This
Yeah.
is just getting older. See you later. Okay. So the levels are really not giving us everything we need to know about that experience. Number one. Number two, one of the most misdiagnosed things in menopausal women who are active and athletic is low energy availability. And we see this in the reproductive age women. They have LEA, their menstrual cycles are gone. Their PCP just throws birth control pills at them without addressing the LEA. And that doesn't help anybody. Same thing happens in menopause. Menopausal women have LEA too, and it is rampant. So if she is having these symptoms and you're jacking up the estrogen and they're not being helped, well, maybe it's not that she's a poor absorber or she needs higher levels. Maybe you're missing something. Maybe she's an LEA and we need to start addressing that. So if we focus too hard on these levels and forget about the experience and the symptoms, that's going to lead to suboptimal care and potentially risk of giving medication that one doesn't need or at levels one doesn't need, and increased risk of side effects and complications.
100%. So let's take it to the bone health part because a lot of people are very interested in using hormone therapy to prevent osteoporosis for bone health reasons. And they give that therapeutic point of 200 or 60, for UK, United States measurements. Where does that come from? And what do you find in the literature as far as like bone protection?
I don't know where that comes from.
Well, 1985 is where it came from, but I found
Right.
I found a 2002 study that said we still don't know therapeutic levels for bone health. So,
Well, it's got to be different for everybody. I mean, if you have a sedentary woman who, maybe gets 50 grams of protein a day
mm,
and, she
oh,
doesn't take
fair.
great care of herself, and you have another woman, body mass index, everything else being equal, who weight trains 3 times a week, takes creatine, gets a lot of sun and vitamin D,
Right.
lifts weights 3 times a week. I would bet you that she doesn't need as much calcium, that she doesn't need as much
Interesting.
estradiol to keep her bones healthy. So to paint everybody with a broad brush, especially when it comes to bone health, where, genetics actually plays the biggest role, and you can't control that with therapeutic levels, there's a lot of factors there. But what we do know and what we learned in the early 2000s, I remember when this happened, I was a resident at the time. Yeah, I was a late resident, early fellow, where they were discovering that ultra low doses of estradiol were imparting benefits, significant improvements in bone mineral density and fracture reduction at even these ultra low levels. So the drug companies actually created new patches
Mm.
to give people the option of using these very low doses to help improve bone health. Now, where some of the other literature might be saying, well, there's a dose dependent relationship. Having a 0.025 patch will be helpful, but 0.05 may be even more helpful and may have a greater gain in bone density. And I think that is true. We know there's a dose response relationship, but what about in the woman who had a blood clot? What about in the high risk woman who really wants to keep her estradiol levels down? All she may need, that 0.025 patch, may do what she needs. And then you focus on the weight training, the protein intake, and all of those other ancillary things that can help with bone health. So we've known for almost 20 years that ultra low doses of estradiol actually do help with bone density. And so to say that one needs to be in this 200 to 300 picomole range just isn't supported by the literature.
I lost my train of thought. Sorry, Carrie, you're gonna
I
have
know
to
I got on
edit
my
that out.
soapbox here. I
No, that
apologize.
was really good, and I I appreciate that. What was I going to say? Oh, I know what I was going to ask. So taking taking this to the next question I have, what do these levels that you find on these tests tell you about what's happening in the tissues themselves and with the receptors? Do we know that?
I think what you can say, again, this is what does the test tell you? The test tells you what the estradiol levels are in the circulation, meaning in that vein that you took it from in your arm or wherever. That's what it tells you. How estrogen behaves in different tissues is vastly different. We know this to be true because of some of the new medications that are coming out called tissue-specific estrogen complexes and selective estrogen receptor modulators. What these medications do is they take advantage of this very fact that different tissues utilize estrogen differently. And so with these new medications, you are able to target endometrial tissue and maybe protect breast tissue, or, you target one thing and to protect the other, like bones, like what's the not Blizovi, that's a birth control. Basodoxifene. Basodoxifene is one of these tissue-specific estrogen complexes that helps to improve bone density, but it is very protective of the breast. So you might want to consider this in somebody who's a breast cancer survivor, if you're going to do that. So we know the tissues have a different environment. And what that blood level is telling you is what's happening in the circulation.
Yep, that makes sense. And then finally, do we know, similarly as we talked about bone health, do we know how different levels, if you will, affect cardiovascular health? One of the studies they cite from 1996 shoots for 100 picograms per milliliter as the optimal, quote unquote, optimal treatment for hot flushes, prevention of bone loss, and cardiovascular protection. So I'm wondering, like, where did that was a long time ago. What is the thinking now?
I mean, I think in the Menopause Society position statements, they go into, cardiovascular disease prevention and bone health. And they look at, I give them a lot of credit. These position statements really address the gamut of things one could possibly use hormone therapy for. And they tell us where the data is, where the data isn't, where it's lacking, et cetera. And again, the focus is not on that number you get back from
They
that
don't give
blood
any.
test.
Yeah.
It's symptom relief is what it is, because there's just so many other variables that impact symptoms and levels for that matter. And I think the authors did a really good job of showing that. And they go into, as you recall, in their discussion section, there's a couple of paragraphs talking about how variable these levels are. And, I think it's also important to talk about who they tested, who were their study subjects. Their study subjects were women who had suboptimal treatment of their symptoms. They weren't getting adequate relief. So that's their study population. And in their discussion, they even say, or in the methods, they even say they don't routinely check estrogen levels. So it's fascinating to me the points that they're proving with what they do on an everyday basis. I would have liked to see them show what are the levels in the people with symptom relief
Yeah.
and what are the levels in the people who don't. And they have such a broad base of patients because they're a huge center. This is Newsom's group,
Yeah.
and they could have very easily done this if they wanted to make that comparison. They could have picked a study population that's appropriate in people who are getting relief symptomatically and do that. The other thing that I didn't agree with their conclusion about is that some women need higher than licensed levels to achieve relief. Well, I didn't see in that study that they took this population, increased their doses, and then took a survey of their symptoms again. We don't know if these higher doses actually brought relief to the patients because they didn't design the study that way. So if you don't design the study that way, you can't draw that conclusion. So what they did do very well was show the incredible variability in lab values in patients who had suboptimal treatment of their symptoms.
I think that's an outstanding point because, to your point, they likely, had they looked at a population that was achieving symptom relief, found levels all over the map, right?
Absolutely. And that's what the position statements of the Menopause Society has been saying for 10 years, is that yes, there's an association between higher levels, but to put these guardrails and these narrow therapeutic ranges in making these your endpoint rather than the symptoms. Although I do think Newsom's group does target symptoms because they don't routinely check levels.
Right, right.
They don't
But it's
routinely
interest
check them.
but it's interesting that they used, and let's just be very abundantly clear. Newsom's group, and this is who was conducting the study, has taken quite a bit of heat for giving two, sometimes three times the licensed dose in patches. And I believe, and this is just my belief, that this study was designed to show, like, hey, yes, we do this, but we're doing this because women aren't absorbing to get what we would consider therapeutic levels based on these studies that we have cited in this paper. However, to your point, I feel, and I agree with you, that we need to take it to the next logical step and say, okay, do they get symptom relief when you do that?
Exactly. I mean, and I think the biggest flaw of the study is this assumption that these levels are the be all to end all, when really the levels should only be helping you in the event that the symptoms are not adequately treated. And that's exactly what they did. They checked levels in people who had inadequate symptom relief and in people who the diagnosis wasn't clear. That's appropriate. What isn't appropriate is the conclusion they drew from this, which is that we need these high levels to achieve symptom relief. Well, you don't know that because the population you studied is not getting symptom relief, and you didn't do a comparison of here are the levels now, and here are the symptoms, and here are the levels on these higher doses, and here are the symptoms. So so some of the things that they are doing are correct, but the conclusions they are drawing from their data are not necessarily correct, in my
It's
opinion.
theoretical,
Yeah, it's
based on,
theoretical.
yeah,
Yeah,
based on
it's based
levels.
on the assumption that these levels are
Yeah.
it, and that's just not supported by the bulk of the literature over the last 10 years.
So then let's talk about this piece that I'm really curious about. So one of the reasons we don't call it hormone replacement therapy, even though I've kind of almost given up that fight because everybody calls it HRT and MHT is never going to really catch on, but whatever. We people push back on that because you are never completely replacing the hormonal milieu of your premenopausal state, right? That we have established that over and over again. But what I find curious is that we never have our hormones are always pulsed. They ebb and flow throughout our entire life since puberty, right? But then we hit this point where we decide it needs to always be in this range and it must always be in this. And that makes zero sense to me. And I'm wondering if we're ever going to go back and be and think, is this appropriate? I mean, is it appropriate? I just, nowhere in our life do we do that. So why do we decide we're going to do this now?
Well, that's why I don't think levels are helpful, because we're using hormone therapy to treat a symptom. Um,
Can you
yes, we
talk about
use,
the usual levels throughout?
sure, yeah, we could
Yeah.
talk about that. So, as a fertility specialist, I have watched so many menstrual cycles, thousands and tens of thousands of menstrual cycles in my 18 years as a fertility doctor. And there's many reasons to do that when people are going through treatment. But sometimes you want to get a baseline. Sometimes you want to see what is this person's cycles doing. And so what happens in the normal, and this is like, say, someone 25 to 35. That's the age line. This is the reproductive age population. In the follicular phase, which is the phase from the time of the first day of bleeding up until ovulation, this is about 10, 12 days or so. Estradiol levels in a lean person and a normal healthy weight person, BMI 25-ish, range between 5 and maybe 60. Okay.
And that's American picograms.
Yes, that
Yep.
is picograms per mil.
Yep.
And then what happens is as the estradiol starts to rise, when it gets to 100 or 200 picograms per mil, this is a signal to the pituitary gland to secrete the LH hormone that's going to ovulate the egg. Because that estradiol of 200 is the way the ovary tells the pituitary gland there's an egg ready. And this is how we as fertility doctors know how many mature eggs about is this, does this woman have in her ovary? She's getting treatment. If she has an estradiol of 600, she's probably got 3 mature eggs there. So we use kind of that 200 standard, as, okay, there's a mature egg there. So then 200 to 300 is usually what we see for one egg. The egg gets ovulated. That estrogen level drops like a stone. Within 24 hours, it could be down to 150. Okay. And then, progesterone levels will now start to rise from like less than 1 all the way up to 20 at the peak luteal phase. Sometimes they even go higher. But that estrogen level is dropping like a stone. And so within a few days of ovulation, it's down under 100. So for the first, say, 7 or 8 days and say the last 7 days, that's 15 days out of the menstrual cycle in a normal reproductive age woman, she is in an estradiol level less than 100. That's where she is. And surrounding the time of ovulation is when she's getting up over 100, up to that 200 or 300 range, and then coming back down again. That's pre and immediately post-ovulatory physiologic levels. So that's what our hormones do when we are cycling regularly in our reproductive age.
So they are probably always somewhere in that 60 to 150 picogram per milliliter
It's
range.
pretty universal,
Okay.
any woman that you check. Now, like I said, there's some variation with body mass index because women with more adipose tissue tend to harbor more estrogen because estrogen
Hmm.
lives in the adipose tissue. And so they tend to have higher levels. So they may live at a baseline of 20 or 30 rather than 5 to 10, which you might see in a leaner person. And these are just rough guidelines
Yeah, I
of what we
understand
see.
that.
They're trends. They're trends. We do tend to see higher levels in people with more adiposity than people who are leaner.
Is there any relation to what you just said and the higher breast cancer risk that we see in women with higher levels of adipose tissue, of fat levels? Because
I'd have to dig into the literature for that question. I
I
don't
know that
know
that's
that.
been hypothetically put out there just over the years of writing about this stuff, but I
Yeah,
don't know.
yeah. I mean, there's a lot to unpack with that, but where a clearer association exists is with bone density. We know that a risk factor for osteoporosis is a lean body habitus, and that heavier women or women with more adipose tissue tend to have better bone densities or more
Yeah.
favorable bone densities than leaner women. And so that's an example of how those higher levels of estrogen can impact physiology with respect to bone. But
Yeah.
I think it's a great question about breast cancer risk because it's hard. There's a lot of confounding variables with that,
Mhm.
right? If you have a morbidly obese woman who is, morbidly obese, what other habits and lifestyle factors that could be influencing her breast cancer risk coexist with the obesity. And the
Mhm.
same holds true for lean people. What environmental and lifestyle factors coexist with lean body habitus that may be favorable or unfavorable for osteoporosis or breast cancer. There's a lot of confounders there that would have to be sorted out.
So generally speaking, to answer my original question about having this sort of artificially steady, stable level of hormones, it's unnatural, but is it problematic?
I don't think it's problematic because, again, we're not trying to recreate the hormonal environment
Hmm.
of reproductive age. It's impossible because
Yeah,
there's receptors, there's enzymes, there's all these things that change. You can't simply, even if you try to give the estrogen in a pattern that is supposed to mimic
yeah,
the menstrual cycle, that doesn't work because there's so many other things that have already changed that you have no
gotcha.
control over. So we're not trying to do that. What we're trying to do is to treat symptoms.
Yep.
And it's perfectly reasonable for that. Which is why, there's such great data behind hormone therapy and why we use it as a tool. But again, it's all about symptoms.
Yeah,
And,
we keep coming right back to that.
it comes back to what her experience is. And, to my younger generation of doctors, my God, sit down and talk to your patients. Just put your phone down, put your tech away, and have a human conversation with your patient for an hour. And you will learn more from her in that hour than you will ever learn from any blood test you do.
So I would like to wrap up talking about my own experience a little bit and getting your feelings on this because I got my levels tested through Inside Tracker and I found it interesting because I started the hormone therapy in June, the estradiol, and it's just a 0.25 gel, like very, very low. But in my own experience, so I had my levels checked in January, June, and just a few weeks ago in December. And they went from 15 picograms per milliliter to 24 in June, back to 15, but my hot flashes have not returned. Like they're still gone, even though my levels are back kind of where they were. And um, Inside Tracker seems to set the ceiling of optimal. They have an optimal zone at 30 picograms per milliliter. And I do not know where they got that. I dug a little bit, but I was not able to find it. I would have to probably call somebody. What's your thought on that? Like, why would they go up and down and I'm still like not having symptoms?
I think it's fantastic that your hot flashes are being helped with a 0.025 patch. That's awesome. And I think different people have different sensitivities to medication.
Mm.
I mean, I can't tell you how many patients come to me, we're about to do anesthesia for, their egg retrieval, and they'll say, I am so sensitive to medication. You have to give me a baby dose because it's going to make me nauseous, it's going to make me this. And there's really people like that. There's people who can get rid of their headache with 200 milligrams of ibuprofen, and there's other people that need 800. There are varying sensitivities due to various physiological factors that 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 influence the what's effective. And you are utilizing or that estrogen that you're taking in that low dose patch is your body is taking to it. It is absorbing it, sucking it up. It's doing everything it needs to do to help with your symptoms. But someone else, might need a higher dose just because their physiology is different. So I think it's fantastic that you're able to use that low dose. And I wouldn't go up. I wouldn't go up. Your symptoms are,
Oh no, I
your
have
hot
no
flashes are
desire to go
great.
up.
So, no, but somebody who's shooting for certain levels, like if you had a doctor that was managing your hormone therapy and wanting you to achieve certain levels, then you would be subtherapeutic in their eyes.
Oh, 100%.
Even though your symptoms are fine, you'd be
And
like,
my
oh
bone
no,
health
you got
is
to get
good.
to yeah,
Yeah.
exactly. So for some, and I think you're a great example. You are an example of a person who does not need to be in the quote unquote therapeutic range. Because if you did just shoot for the number, you would be putting yourself at greater risk by having the higher estrogen levels.
And I also might feel like hell. Like when I was on that
Right.
fem ring, I mean, I was nauseous, I had headaches. I don't know where my levels were at that moment,
Mhm.
but it doesn't matter because I did not feel good.
Right.
I'm wondering like why even if you're taking a exogenous form of estradiol, your hormone levels might still fluctuate.
Because there's other factors in the body that are metabolizing them. You know, it's how the liver manages it, it's how the kidneys clear it. Those things, you know, liver physiology, kidney physiology can be influenced by many things. Like, you know, if you're dehydrated, you know, if you
Oh,
just did a race and you are naturally dehydrated because you just did a triathlon, your kidneys may not be clearing things quite as well because they're trying not to clear water because you need water, you're dehydrated. So different things you experience in everyday life impact how our liver functions. You know, how, you know, if you go to a New Year's Eve party and you have, you know, 3 drinks, your liver is going to work differently than it did before that. So I would suspect that fluctuation in levels is probably due to different physiologic factors that were variable during that time.
excellent. Is there anything that we have not talked about regarding this whole topic that we have covered on testing and the therapeutic levels that you would want the audience to know that we have not talked about, that we have not covered on this topic?
I think, you know, patients need to be aware when you're looking for a doctor, you want someone who's going to listen to you because there are so many factors that go into the menopausal experience and so many things that have to be looked at to help you have a better experience and to help you find symptom relief. It's not all about the lab tests. The lab tests are important to help guide the conversation and to help guide figuring out what is going on. But the be all to end all is having that conversation. And so my suggestion when people are looking for a provider is to find someone who is willing to sit down with you and really learn about what are you experiencing? I want to know the whole story. This is how I start out every single consult I do is they fill out a questionnaire and it has their most important things they want to discuss and they say, tell me about it, start to finish. And then they talk and I learn. And then we order labs at the end. We don't start talking about labs, you know, unless they brought labs with them, you know, obviously we'll talk about them. But that's at the end of the conversation because I really want to know, you know, what it is they're experiencing because you learn so much and lose so much when you're just focusing on numbers.
100%. And I also think that I keep losing my train of thought. I had a point. I'm so engrossed in this conversation. Sorry, Carrie. Um, I was thinking about that in
One thing we didn't talk about
yeah.
yet is the dose response and complications. What are the risks of
Okay,
having estrogen doses that are too high?
we can talk about that. Yeah, I mean, I think the only point that I was going to make was that in every other aspect of our life, like we, take endurance sports, like I don't have a particularly high VO2 max or a high heart rate, but that never, it's what I did. It's all the things that I can do within my own physiology that work for me, right? Like you just can't look at somebody on paper and be like, that person's going to succeed. It just doesn't work that way. It's kind of like where I was going to go with that, but it's not important. So let's talk about that quickly. I will lead us into it.
Okay.
I think that's all a great point, and I also think that it's worth talking about for people who feel, and I know that there are quite a few people who do feel like they need to hit these numbers, they need to have these like high numbers. I have always said, just to your point, just take stock. Like this is a time to take stock. And that's what I've done. My levels are like 20, right? That I would be suboptimal, but my heart is good, my arteries are clear, and my bones are strong, and I feel great, and I'm training well. Why would I try to artificially raise myself somewhere that just might not be healthy for me? And I think we need to talk about that. Like sometimes this might not be healthy for you to be in a different artificial place.
Absolutely, absolutely right. It's funny. As you were saying that, I was remembering a client that I've been taking care of for years, marathon runner. I mean, like elite level, and she is taking testosterone. I prescribed her testosterone. Her levels are in the single digits, but she feels freaking amazing.
Yeah.
And she's performing well. And she always says to me, I know my levels are this, I know, but I don't want to go up because I feel really good. I'm like, I don't want you to go up. What I care about is that you feel good. But the potential risk of going above and beyond your symptoms to achieve a level is that what we do know and is supported by literature is that the potential complications
Mm.
of hormone therapy are dose dependent. And some of the things that are well supported by the literature is blood clot risk. And I know that people think that if you're using transdermal, you have no risk of blood clots. That is not true, especially at these higher levels. Okay. It does not negate the risk because the liver still sees the estrogen from the hepatic artery, which is taking from the rest of the circulation. First pass liver effect is when you swallow a pill and the intestinal blood system takes it to the liver as its first pass, detoxifies it before it sends it to the rest of the body. When you put a patch on, it's getting into the circulation and going to the liver through the hepatic artery. It's going through the back door. So and I do feel it's important to take the time to talk about this because people poo-poo this all the time. The NuvaRing. The NuvaRing is a vaginal ring. It's a contraception that avoids the first pass liver effect. But guess what? Sex hormone binding globulin is through the roof in people who take NuvaRing. That is a protein produced by the liver, and it's the same protein that goes up when you're on birth control pills. So again, it is really important to know that the liver still sees this stuff, even if it's coming through a patch, even if it's coming through a vagina, and the liver, it's impacted by it, as evidenced by the sex hormone binding globulin increase. And that also increases risk of blood clots. So the risk is not zero. And the risk goes up as dose goes up. And the reason we care so much about blood clots is not just because of getting a blood clot in your leg could become a pulmonary embolism, but blood clots are the underlying physiology of heart attacks because
Hmm.
you've got clots that break off in vessels that lodge in tissue and kill the tissue beyond it. It is the underlying cause of stroke, ischemic stroke, where again, blood clot breaks off and goes to the brain and kills the brain tissue beyond it. Migraine headaches and stroke. We know in reproductive age women taking birth control pills that there is a dose dependent relationship between stroke risk and the estradiol. Also, dementia. The most common cause of dementia is ischemic dementia, which again is due to those little tiny blood clots that kill off brain tissue because they get lodged there.
Right.
So there are some main things here, cardiac and cerebral events that can happen and that are a greater risk if you go to these higher levels. Breast cancer is a little bit more fuzzy, because of the debate on what exactly is the risk of breast cancer. Is it increased? Is it not? If you take estradiol alone, maybe it's protective. If it's combined hormone therapy, it increases. But I think despite all the fuzziness there, most professionals would agree that the longer the dose of estrogen exposure, the greater the relative risk of breast cancer. Now, that's different from a higher dose at any given time. That's more long duration. But greater estrogen exposure could be causing an increased risk of breast cancer in people taking combined hormone therapy. But the thromboembolism risk is the big one that is the most clearly supported by data and is the reason why the Menopause Society says go with the lowest dose that solves your symptoms, that cures your symptoms. Because if you go higher, now some of the complications and the risk go higher. And that's the danger of shooting for levels and not for symptom relief.
Yeah. No, it makes a lot of sense. And people often push back and they say we shouldn't be afraid of hormones or natural hormones that our bodies produce, but the dose is like whatever is working for you, again, is the level that works for you. And dose makes the anecdote and the poison in each individual one of us, right? There's no magic number to your point.
Yeah, and what achieves symptoms in one is going to be totally different
Yeah.
than another person, not just due to absorption of medication, but due to her overall physiologic
Yeah.
state and her lifestyle factors. And again, I want to make the point, I am not anti-lab or anti-level. I have drawn more labs and gotten more levels on women than most doctors have in their whole career. And it's just you want to know why you're drawing them, and you want to know what is it going to tell you and what is it not going to tell you when you get the result. And that's those are the rules that I stick by when I'm ordering labs.
Excellent. Well, thank you as always. And until we dig into another study, I appreciate you always coming in and lending your wisdom to the show.
No, it's always a lot of fun. Thanks again for having me.
Well, that's our show. Come on back next week when I sit down with Normie Kodo, who is a writer, teacher, and runner. And she came to my attention with a blog she wrote titled Running and Menopause: The 9 Ways I Made It Through the Roughest Running Year to Date. And we talk all about how often in menopause, when you're in it and going through it, especially for active and